Welcome, everyone. Good evening. Thank you so much for joining us for fourth session of Child Mental Health Community of Practice, Eating Disorders. I would like to formally start the session by acknowledgement of country. Northwestern Melbourne Primary Health Network would like to acknowledge the traditional custodians of land on which our work takes place, the Wurundjeri Woi-wurrung people, the Boon Wurrung people, and Wadawurrung people. We pay respects to elders, past, present, and emerging, as well as pay respect to any Aboriginal and Torres Strait Islander people in the session with us today. Just some community of practice guidelines. So we agree to stay on mute unless speaking. Raise your hand to speak. Keep conversations confidential. If possible, keep camera on. Introduce yourself and your role when speaking. As that community of practice, we aim to improve collaboration between practitioners involved in children and adolescent health in different capacities. Share ideas and promote everyone's participation. Acknowledge that we have varied learning needs and interests, and no question is silly. So just about that, during the education component, please ask questions via the chat box. And this session is being recorded. Please ensure that you join the session using the name you registered with so we can mark your attendance. Certificates and CPD will not be issued if we cannot confirm your attendance. Just on how to change your name in Zoom meeting. So click on participants. If you are using an app, click on your name. From desktop, hover over your name and click the three dots. From Mac, click over your name and click more. Click on rename and enter the name you're registered with and click done, change and rename. And we are all good to go. So we have Dr. Prakash with us. He's a senior consultant child and adolescent psychiatrist at RCH with over 20 years experience. He has worked in and managed general and specialist clinics within child psychiatry in metropolitan and regional public mental health services. He has worked with children and adolescents from 4 to 18 years of age, assessing and managing a variety of mental health issues. I'm Saha. I'm a GP who works in Sunbury, and my area of interests are child and adolescent mental health and chronic disease management. And we have our very special guest speaker for today, Dr. Michelle. She's a pediatrician and adolescent physician in the Department of Adolescent Medicine, as well as looking after adolescent patients with chronic illnesses and complex medical and psychosocial needs. She's also the medical lead for the RCH Eating Disorders Service and enjoys the multidisciplinary aspect of patient care. I'm just going to hand it over to Dr. Michelle to present the education component for today. Thank you, Michelle. You'll have to unmute yourself, please. Thank you.
I'm just going to share my screen. Can that be seen?
Not yet.
Not yet? Okay, hang on. Now, is that better?
Yes, thank you.
Okay, brilliant. I've got things popping up everywhere. So this picture was actually drawn by one of the patients a long time ago, and this is how they perceive themselves. Interestingly, at that time, she did perceive herself as actually not overweight, but she was still unable to eat. And I'll go through a little bit more around eating disorders. So what we know is that screening tools are not particularly sensitive or specific for adolescents. And actually, the NICE guidelines, which are put out quite a long time ago now, which have now been superseded by MEAD, and I'll talk a bit more about MEAD later, suggest that actually thinking about the possibility of an eating disorder is your way of actually kind of screening for it and actually asking the questions around eating. So what disorders will you see? I guess most disorders would present more in a subclinical fashion when they're in general practice. However, they may get to clinical level as well. So what we most often see is anorexia, bulimia, avoidant restrictive food intake disorder, and other specified feeding and eating disorders, namely atypical anorexia nervosa. Binge eating disorder is probably really common but under-recognized. And we don't see it at the Children's Hospital Eating Disorders Service, mainly because we have chosen to focus on restrictive eating disorders, because that is the pointy end and causes, acute morbidity. And then there's pica and rumination disorder, but we don't have a lot of time to go into that today. So we know that adolescence is actually the peak age of onset of eating disorders, and it is actually the third most common chronic illness in females, and behind asthma and obesity. And now it is understood that it affects all ethnicities and social groups, whereas in the past it was conceptualized very much as a white female disease in rich countries. The more we know about it, the more I think we recognize that it does affect all ethnicities and social groups. The lifetime prevalence of anorexia is between 1 to 2% in females, and of that, about 10% occurs in males. The overall incidence has been stable, but we've noticed that there is an increasing trend in adolescent females. And anorexia nervosa occurs much earlier than bulimia nervosa. So they tend to present in the younger adolescent age groups, whereas bulimia tends to present in the older age groups, such as the 16 and 17-year-olds. Bulimia is a little bit more common, and the lifetime prevalence sits, between, I think it's 2 to 3%. I think that's a mistake there. And of these, 0.5% are males. I'm not sure whether you have noticed, but certainly the COVID pandemic has increased presentations of eating disorders worldwide. And this is the numbers that we've actually seen in our eating disorder service up to 2021. The trend in 2022 had also continued, and we haven't so far seen a market slowdown as yet. And what's also interesting is that it wasn't related to lockdowns. So all hospitals that looked after eating disorders worldwide saw increased numbers, and increased numbers were presenting to emergency departments and outpatients as well. So, I'll go back a bit. So anorexia. What drives anorexia is a distortion in one's body image and a huge concern about their weight and shape, believing that they're overweight, and therefore there's this intense fear of gaining weight and becoming fat. And in teenagers and young people, what I think we need to remember is that low weight is not, there's no cutoff. It's a weight that is less than minimally normal or less than minimally expected for them in terms of their growth. As you know, with teenagers, they continue to gain weight as they grow. So even not gaining weight whilst they're gaining in height is a concern. Then there's there are behaviors, if they're not able to articulate why they are fearful of gaining weight, there may be behaviors that, interfere with weight gain, such as, consistently saying at the dinner table, I'm full, I'm nauseated, I can't eat. And so there are all these behaviors that present themselves at the dinner table, and it's really useful to speak to parents about what they see when they present the child with food. There are two subtypes. So one is the restricting subtype, and then the other is the binge purge subtype. And I'll talk a little bit about how you distinguish that from bulimia a little bit later. In atypical anorexia nervosa, which comes in under the category of other specified feeding and eating disorders, individuals meet all the criteria for anorexia with the exception of weight. So they are actually within their normal weight range, or they could be overweight despite the weight loss. So they have typically come from a higher weight, and sometimes we actually have patients referred from the weight management service with atypical anorexia nervosa without being underweight, but they have lost a significant amount of weight. They are physiologically unstable, and they actually demonstrate all the other signs of anorexia nervosa except that they're not underweight. Bulimia is characterized by recurrent binge eating, and then alongside that, compensatory weight control behaviors such as purging or laxative use. Whilst their self-evaluation is influenced by body weight and shape, it is certainly not the huge drive that you see in anorexia nervosa. In anorexia, there's this persistent drive to lose weight. And if you actually plot their weight over a period of time, you'll find that bulimia patients kind of fluctuate more, whereas the trajectory for anorexia patients is just downhill. The behaviors have to be present at least once a week for about 3 months before we call it bulimia nervosa. And binge eating is actually eating, a very large amount, more than anyone would in a similar situation and time period within a discrete setting. And there has to be a sense of lack of control over eating during these episodes. I'll come and talk a little bit about ARFID now. So ARFID is avoidant restrictive food intake disorder. And this term was newly coined in DSM-5. And what ARFID is that it's a feeding or eating disorder that is associated with at least one of 4 of these things. So substantial weight loss or failure to gain weight, similar to anorexia in growing adolescents. It could lead to a major nutritional deficiency. It might lead to a dependence on oral nutritional supplements or nasogastric tube feeds, and or marked interference with psychosocial functioning. Now, how it is different from anorexia, it is that it's not associated with any body image disturbance. It's not due to scarcity of food, such as in neglect cases, or related to, fasting or other religious practices. It can coexist with medical or psychiatric problems. But if you actually take away or treat the medical or psychiatric problem, the eating problem, actually does not resolve. And I'll give you an example of this. I've got a patient who has Crohn's disease and also likely to have functional abdominal pain alongside the Crohn's. Which then also leads to having difficulty with eating. And sometimes it's difficult to tell what's Crohn's, what's functional abdominal pain. They are underweight and they are not growing. they have multiple nutritional deficiencies. So how do you tease that apart? So we treated the Crohn's, looked at the blood markers, did a scope. The actual Crohn's disease was minimal, as were the blood markers. But the young person still had significant abdominal pain, still refused to eat. And therefore, this was ARFID related to functional abdominal pain in a patient with Crohn's disease. Does that kind of make sense? Similarly, you could have a child who has anxiety, generalized anxiety disorder, but if you treat the generalized anxiety disorders, they still have nausea and can't eat and have substantial weight loss, then this is called ARFID. Now, ARFID's a heterogeneous disorder and can present, in three major ways. One is sensory food aversion. So the young person or child may have, an aversion to how a food looks or tastes or its texture. And they may end up with a very restricted range of foods. The second way it can present is in lack of interest in eating. So just no drive to eat at all. And they tend to have very low appetites and get full very easily. And you can see how this lends to actually not eating enough to be able to grow. The third way tends to present in a more dramatic circumstance. So more in the way of an aversive experience occurring and then becoming fearful of that aversive experience. For example, a child who had a choking episode, patient of mine who actually choked on one of those potato sticks that you get at fairs, and thereafter had this sensation of something being in her throat and not being able to eat any solid foods. And her intake just became more and more restricted over time. It can present with functional abdominal pain, and therefore the abdominal pain leads to that fear of eating. And this group tends to present much more acutely with weight loss, whereas groups 1 and 2 tend to have that long-standing kind of, lack of weight gain more than anything. And what's also interesting is that, the mixture of all three can also present in the same patient. Prevalence has been measured, and it depends on where you look, I guess. So it's been a study in tertiary North American pediatric centers in eating disorder programs, and it's high as 5 to 14%. A Swiss community-based study was 3%, and in an Australian population-based study, greater than 15 years was 0.3%. Males are just as likely to present with females and may be overrepresented. They tend to present at younger age groups compared to anorexia, and also very common to have comorbidity. So anxiety disorder in 50% of ARFID children in one study. OCD and ASD is also really common. And what they've noticed is that young people can be as malnourished as AN patients. So if we compare the eating disorders across, what you see in anorexia and atypical anorexia is significant weight loss, whereas this is not present in bulimia. And ARFID, maybe. Are they underweight? Yes, or in anorexia, or not yet in atypical anorexia. If you let them go for longer, they will become underweight, and then they'll turn into anorexia. not in bulimia, and maybe in AFID. Do they have body image disturbance? Yes, in anorexia. They have some body image disturbance in bulimia, but not in AFID. What about binge eating? They may binge in anorexia. And the other thing to say, I guess, about anorexia and binge eating is that if you see their weight going right down, that's anorexia rather than bulimia. So anorexia always trumps bulimia. And AFIDs don't binge eat. Are there compensatory behaviors such as fasting, laxative use, or compensatory exercise? Maybe in anorexia and atypical AN, yes. In bulimia, no. In AFID. Hope that makes it a little bit clearer. Sometimes it's hard to know, and sometimes you have to watch them over time. So what's the best practice approach in primary care? A lot of it is trying to establish rapport and kind of look for a working diagnosis, assessing their physical status and their psychological status, excluding any underlying physical illness, and then referring. Sometimes if you're referring within the private system, it is needing to coordinate care within that, and then ongoing monitoring of their medical and psychological state. So I find that the helpful questions are, for me, a history of eating behavior over time. So how did they eat, as a child or toddler? Were they, very selective? Did they diet in early primary school years, late primary school years and in early secondary school years? I tend to take a 24-hour dietary history just to have a look at what patterns of eating are like. What is the pattern of avoidance? Were they skipping meals and snacks or reducing portion sizes? And typically what young people tell me is that they start by trying to become healthy, where they try and cut out junk food. Then they start skipping their snacks. Then they try and reduce carbohydrates and dairy products and meat, and so much so that they end up virtually eating very little. I ask about binge eating. I ask about purging. Try and find out what their maximum weight and minimum weights are. Some young people, the ones with AN, can tell you exactly what weight they were and when. What do they think about their body, and which bits of their body do they not like? I ask about exercise and how much they do. So include PE and all their scheduled co-curricular activities and extracurricular activities. I also ask about private exercise, like exercising in their rooms, doing sit-ups and push-ups, or walking. In girls, I ask about periods and whether their periods have become less regular or stopped. And then I ask about the psychosocial history. So what's happening at home, at school, with their friendships. And I ask about mood and drug, sex, rock and roll, to understand a little bit more about the context in which the eating disorder has developed. I also ask about family history of eating disorders and if there's any psychopathology in the family, because we know that there's significant genetic loading in lots of eating disorder presentations. And then I think it's important to look for comorbidities, so depression and anxiety, ASD, and I forgot to mention OCD as well. And then examination would be checking their height and weight and having a look at where their BMI sits, but being very careful about knowing that BMI actually changes with age. So BMI cutoffs in adults are important, but they certainly are not that important in children and adolescents. They typically have a low temperature and they are typically bradycardic, and they often have postural tachycardia. So I get them to lie down for about a couple of minutes, check their pulse rate, stand for a couple of minutes and check their pulse rate and blood pressure. They often are hypotensive. I'm talking much more about anorexia now, and they tend to have postural hypotension. Try and get an idea of what their perfusion's like. I do their Tanner staging to determine where puberty is occurring. And then I think in terms of signs of severity of anorexia, sometimes when they're really underweight, you can actually see that they're cognitively slowed, they're cachectic. Peripheral edema worries me. And certainly if they're unable to sit up without using their arms from the bed or squat to stand, that's another sign of them being really quite unwell. And then look for Russell signs in terms of signs of purging. And sometimes they have little chipmunk faces from purging lots because they've got a parotid inflammation. So the investigations would be to try and exclude any organic disease that you haven't already uncovered on history. So diabetes can masquerade with weight loss, as can hypothyroidism. Inflammatory bowel disease we always think of, and celiac disease are the much more common ones. So doing an ESR-TSH celiac screening for what test urine and blood sugar level is usually helpful. And then it's also checking for complications of eating disorder themselves. So nutritional deficiencies, do their electrolytes, calcium, magnesium, phosphate, only because when you refeed them, you can get electrolyte shifts, especially in terms of their phosphate and magnesium levels. In girls, I do an FSH, LH, and an estradiol, and I do a bone age to see what their bones are like as baseline, as well as a DEXA scan. So in terms of treatment, what are the psychosocial treatments that actually have evidence? Certainly, it's well established that in anorexia and atypical AN, family-based treatment is the gold standard of care. And then there's level 2 treatment, where systemic family therapy and cognitive behavioral therapy enhanced are the two other treatments. Adolescent-focused treatment is also used, but not that commonly here. And now, I guess, there are adjunctive treatments that are added on to the FBT, and other treatments here are multifamily therapy and temperament-based treatment. And I can explain a little bit more about them a little bit later if you wanted to ask me questions. Certainly in bulimia, the evidence is not quite as clear as in AN. FBT and CBT have been found to be useful. And in ARFID, this field is only just developing now, but we have tried FBT with unified protocol, and unified protocol is a little bit like CBT, and it cross-cuts many diagnoses in terms of treatment of anxiety. So we use that in conjunction with FBT. CBT AR is another treatment module which is aimed at the individual. However, in children, young adults, in young adolescents, we prefer to use FBT to try and motivate the family to help the young person kind of gain the weight they need before then addressing the specific concerns around the eating behavior and the anxiety around eating. What really worries us is any rapid weight loss over a short period of time. So these patients are actually more likely to become medically unstable, so bradycardic and hypotensive. If there is a period of starvation or very low intake followed by increased eating, and that's worrying, because that's when you see the refeeding syndrome developed. And the other thing that we worry about is hypokalemia due to frequent vomiting. The Children's Hospital guidelines are also the safer care guidelines, and you can find them on the Royal Children's Hospital clinical practice guidelines page under eating disorders. So what you see in terms of the red flags are the ones that have significant electrolyte disturbance, heart rate less than 50, systolic drop of greater than 20 millimeters of mercury in terms of their blood pressure. So they're the hard cutoffs that end up scoring hospital admission. But of course, the more criteria that you tick off, the more likely that they're going to need admission. Certainly also if their weight is, less than 75% of expected body weight, we tend to admit, because they tend to refeed significantly. We also admit kids who are young and are needing to grow, so we might bring them in for periods of time to try and push their weight up so that they can actually grow during that period of time. And certainly we also admit if they have got out of control compensatory behaviors that we need to try and manage on the ward, such as purging and exercising. Exercise is really, really hard to control. So useful resources here, the RANZCP guidelines is useful. However, that said, that actually is targeted much more to adults. So I mentioned MEAD earlier. So it's the Royal College of Physicians in the UK's medical emergencies and eating disorders guidelines. And they're actually, really good, and they've replaced the NICE guidelines now. What are useful resources for parents and carers? So I think during the pandemic, when everyone was knocking on doors and we were only able to take patients who were really significantly unwell, and they left a whole lot of other patients where, they couldn't access support. Eating Disorders Victoria developed a really good support program. So they do carer coaching and carer courses. They even do telehealth counseling for carers, and I believe that this still continues. So that's been a lifesaver for many families, actually, whilst being on wait lists. The Butterfly program do run a number of online support programs, both for carers and for sufferers as well. But they also need to ensure medical stability. So often what they like to ensure is that the GPs are monitoring patients regularly. And Eating Disorders Families Australia is a good organisation where families kind of empower each other and support each other with children that have eating disorders.